Hey everybody, my name is Nathan Riley. For those who don't know me very well, I'm an OBGYN, a fellow ACOG, and this is a really important topic, bladder infection and management. For anybody who's working with me, but honestly, this is a really important topic for the public in general as well. So I'm going to take you through some of the principles, and these principles are far and wide useful within women's health, and frankly also useful in men's health as well. But we have to start somewhere, and I think an important part of this conversation is how do we screen for a urinary tract infection. A urine dipstick is typical of any prenatal visit, whether you're an OBGYN or any type of midwife. Checking for epithelial cells, red blood cells, protein, leukocyte, esterase, and nitrites is kind of the standard thing that we do on a regular basis. Urinalysis is a little bit better than urine dipstick, but of course you have to send the urine off to a lab. And so you oftentimes start with a urine dipstick, then follow up with the urinalysis if you're actually concerned about something. And the most important thing that people do tend to forget is what are we finding on clinical exam? And this starts with eliciting a history. What are the symptoms, right? If somebody tells you they have some symptoms, you might also start looking for other signs, right? Which are the things that person doesn't tell you about, but you might be looking for. So let's start with this list of common signs and symptoms. Any woman who walks into my practice and she's pregnant could have any of these things. Does it necessarily mean she has an infection? No, of course not. But when we kind of combine this clinical picture with maybe what we're seeing on dipstick, that might prompt us to send a urine culture, urinalysis, those types of things. So here's what a urinalysis might look like. One of my collaborating midwives was kind enough to let me use this. We've taken all of the identifying information off of here. But you can see here we have WBC esterase, also known as leukocyte esterase. That's flagged. We have some trace amounts of blood, which can happen in any sort of inflammatory condition. Imagine if you're out in the cold and the inside of your nostril gets inflamed and dry, it can be cracked, and then you can have a little bit of, a tiny little trace amount of blood that comes out of that, right, from blowing your nose. There's a little bit of blood wherever you can find inflammation in the body. We also have white blood cells here that are cranked up way above 30. So this is enough that the lab saw this urinalysis and then sent a reflexive culture to see if any bugs would grow out. In this case, we have E. coli, Escherichia coli. And right below that we see, okay, this is not just a mixed flora or some sort of contamination or just a little bit of E. coli. This is over 100,000 CFUs, which is important because not every bacteria that grows in the urine is necessarily something that needs to be treated. So we have to be very, very discerning from the clinical exam through interpretation of the urinalysis and even interpretation of the urine culture before we start throwing antibiotics at any woman who has abnormalities on one of these three facets of prenatal care. And as just a couple notes on urinalysis, we're always looking for protein. I'll start with this one. If you see protein in the urine on urinalysis, it's most sensitive to albumin, which is a type of protein that's produced by the liver. Sometimes protein actually is present, but it comes up as a false negative if the urine is way too dilute. So they just chugged a whole gallon of water before the urinalysis, had a big old distended bladder, and then, filled up a cup with, one portion of a whole bunch of almost completely clear fluid. That's a very hydrated person who's just getting rid of that excess fluid off their body. It can also be false positive if the urine is very, very concentrated. Now, these two other pieces are actually very, very relevant. Everybody talks about these with relation to urinalysis. And if both of them are positive, then you have a really, really good chance. If both of them are negative, a UTI is highly unlikely. And then there's going to be some situations in which nitrites may or may not be there, and likewise for leukocyte esterase, which, by the way, remember is also sometimes reported as WBC esterase. Nitrites are produced from some bacteria, namely the Enterobacteriaceae, the Enterobacter species, as a byproduct of an enzyme called nitrate reductase, which converts nitrate to nitrites. So if you see nitrites as positive, it'll be flagged as abnormal. You're most likely going to see Enterobacter on that final culture, which is a very common bacteria that we see in acute cystitis, also known as a bladder infection or an acute UTI. Leukocyte esterase is also an enzyme. This is released from white blood cells. Remember, when there's an infection or bacteria around, the white blood cells rush to the area, start doing their job, and in the process, they start releasing this enzyme, okay? However, if the urine is too concentrated, you actually don't get a breaking down of white blood cells that are actively combating bacteria, and so that could result in a false negative, okay? Even if they're there, you may not pick them up on the assay, which is used in the urinalysis because the urine is too concentrated. And remember, concentrated urine is like apple juice, right? The darker it gets, the more concentrated it is. The lighter it gets, the more dilute it is. I'll just repeat this pro tip here. If neither leukocyte esterase nor nitrites are positive on your urinalysis, a UTI is highly unlikely, and you need to now not say, okay, it's no big deal. We need to understand, why are they having pain in their abdomen, pain in their back? Like, something else must be going on there, okay? So don't just take this as, oh, the only thing that could possibly be causing any of those signs or symptoms is a UTI and we just ruled it out. That's not how medicine works. If there's something that the client or the patient is complaining about, and these are negative, and the culture's not worthy of running, it's not a bladder thing. We have to consider thinking outside the box now and consider, well, what is causing this discomfort or this pain? So here's a lot of these graphics, by the way, are from a document released from ACOG, by ACOG in 2023. What this is showing you is the value of these various aspects of these screens. A dipstick and microscopy are both screens for a UTI. It has to be a positive culture. Stuff has to grow out of the urine for this to be a slam dunk, something that we need, that needs treatment right now. So with sensitivity, we're looking at the likelihood of something being a false negative, and going to do a full sort of orientation to biostatistics. But you can see here that, a lot of these things that we talk so, fondly about, like the presence of WBCs and bacteria, they aren't necessarily the best screens. So we have to actually take the entire clinical picture into account. And of course, if we were to combine leukocyte esterase and nitrites, the sensitivity is almost 100% and specificity is almost 100%. So we actually have a really, really good idea when both of those are positive that, there's a really good chance we're looking at an infection, and the inverse, like I've already said, is true. Where if neither of those is positive, then there's a really good chance we don't have a UTI, and we don't have to continue going down that path. We should actually be also looking elsewhere. So there's a couple categories that ACOG offers from a diagnosis standpoint. Asymptomatic bacteriuria is the first one. This is when a person comes in and we just do a random screen, right, with a urine culture. And it's recommended we do this at least once in pregnancy, urinalysis with culture. Urine dipstick is not sufficient. We want to do at least once a urinalysis with culture in hopes that maybe we'll pick up some acute cystitis that this woman wasn't complaining about but is brewing. And by screening for this, again, with urinalysis and culture, we can prevent pyelonephritis, which of course carries a real toll on pregnancy. We'll get to that in a second. This, as a generalized, or I should say a universal practice in pregnancy, was adopted in roughly the 70s. It was, somewhere between 10 and 15% pyelonephritis was in pregnancy, and by universally screening in this way, we dropped it down to about 1 to 4% of all pregnancies, which is a decrease by about 30% in pregnancy, which is great. That's a really, really good tool for us to have. If a culture is greater than 100,000, remember, this is not symptomatic. This is asymptomatic. We just happen to find a bunch of bacteria in there, but specifically bacteria that are growing on those petri dishes at greater than 100,000 CFUs, we would recommend treatment, even if they have no symptoms. After you've treated them, you do not need to do a test of cure. You can, but it's not a necessarily a cost beneficial practice to do a test of cure, meaning you get a culture and see if there's still bugs there. It's just not useful to do that in these clients. However, if this is negative initially, like let's say in the first trimester, but they have a history of pyelonephritis and recurrent UTI and all of that in prior pregnancies, as an example, or maybe they're immunosuppressed, then repeating the screening on maybe a trimester by trimester basis could be valuable for some clients. Acute UTI. So this is a person who comes in with signs or symptoms of UTI or pyelonephritis, and you get the urinalysis with culture. Now, in the presence of symptoms, it's very reasonable to treat regardless of the culture results, meaning let's say there's only 50,000 CFUs versus 100,000. Because they're symptomatic, we have a lower threshold for treatment in these clients. And remember also that they might have symptoms, but are you sure that those symptoms are related to a bacterial infection in the bladder? This is where our clinical decision and our clinical judgment really comes into play. Let's say they have back pain and there's 50,000 of E. coli or Klebsiella or something growing out, CFUs growing out on culture. You could treat that, but you may not actually be treating the problem. Maybe this person has some other thing that's leading to those signs or symptoms. So we have to consider the whole picture here. However, if they're having the urinary frequency and urgency, and maybe there's a little bit of blood whenever they look in the urine, or the urine smells really bad, and they have, bacteria growing out on culture, then, it would be reasonable to treat them. And if it doesn't work and the signs or symptoms persist, then we have to consider, did we not treat them correctly? Or are we missing something here because we've just gotten so myopically focused on the bladder and the urine? Again, with these clients, there's insufficient evidence to support a test of cure after treatment, if treatment is warranted. Pyelonephritis is the one that we really, really worry about. Okay, so this, if a person comes back with a culture that's consistent with UTI and they have either or a fever or costovertebral angle tenderness, we need to be very, very careful with letting these clients fall through the cracks. If they aren't treated adequately and they actually have a true kidney infection, then we may be predisposing them to preterm labor, sepsis, acute respiratory distress syndrome, and many other really, really bad things, including death. If a person does have pyelonephritis, inpatient management is going to be recommended first and foremost. We would be giving them a total of 14 days of therapeutic antibiotics. Okay, that might mean a couple days in the hospital until they've kind of restabilized with no fevers, no pain. They're feeling better, right? We send them home to continue for a total of 14 days on a therapeutic antibiotic. But we start this, generally speaking, in the inpatient setting. There are exceptions to that, like if a person doesn't have a hospital nearby, but that's going to be the standard of care. After you've completely treated them, you could, of course, get a test of cure if you'd prefer. There's people that argue in both camps, but regardless, you're going to put them on a low dose of something like nitrofurantoin for 100 milligrams daily until about 4 to 6 weeks postpartum, after they've completed 14 days of therapeutic appropriate antibiotics for their particular infection.
This test might be
Here's how we check CVA tenderness.
A number of conditions, including kidney pathology or low back pain. If your patient comes in with low back pain, it's important to think about the fact that they might actually have some kidney issues. So that your patient or your student might be palpating this area, asking if there's any tenderness, and then place their hand at the costovertebral angle and hit it. A positive sign would be if the patient kind of flinches and reacts to that punch over this area.
Okay. That guy was underplaying the type of reaction that people will have when they have a real kidney infection. They will jump off the bed and threaten to kill you. That's how intense that pain can be. All right, so here are the principles of treatment. You want to treat for 5 to 7 days. Outside of pregnancy, we can usually get away with anywhere from 1 to 5 days, 1 to 3 typically, even in older people. But in pregnancy, we're going for 5 to 7 days to make sure we've completely cleared them out of this infection. We will also want to use the lowest effective dose and consider which antibiotic, or which trimester they're in when you're selecting an antibiotic. You're going to let the culture / sensitivities guide your antibiotic selection. If you're not familiar with this notion of gram positive, gram negative, and all of that, you got to at least look at the sensitivities report, which will be accompanying your culture in order to select an antibiotic. A lot of people were like, well, what's your favorite antibiotic to use to treat a UTI? That's not the right question. There's specific antibiotics that work against different types of bacteria, and so we need to know that, and we need to know where are they in their pregnancy? What's their medical history? Because there's certain people at certain points in their pregnancy that really shouldn't be offered various antibiotics. And we'll look at a sensitivities report in a second. And lastly, principles of treatment is always to start promptly, especially if you suspect pyelonephritis. So here is what we call a sensitivities report. This will hopefully always come with your urine culture. And if if a lab knows that a person is pregnant, they're going to run a different sensitivities assay, so to speak. It's not really an assay. What they do is they take the petri dishes and they add antibiotics to each one that grew, and they really want to see which of these antibiotics kills off the bacteria. Certain bacteria have developed a resistance pattern to various classes of antibiotics. And in the community, let's say that you have your urinalysis and the symptoms of your client look really bad. Well, you might say, gosh, this really seems like a UTI. I want to start an antibiotic. That's fine. Because then when the culture comes back and the sensitivities report comes back, if the antibiotic we've chosen is not the right antibiotic based on what we see here, and I'll explain this in a second, we could then switch them to the correct antibiotic. But because people haven't been good stewards of antibiotics, we have developed, let's say, ampicillin. We have a high ampicillin resistance pattern in many communities in the United States. And therefore, if you're going to treat what I call, what's called empirically this UTI, which is when you start it before the culture's back and then you have a willingness to change to a different class of antibiotics, if the report says that something is resistant, you're not going to start with something that already has developed a high resistance pattern in the community. But let's look at this particular client's sensitivities report. We've got ampicillin, amoxicillin, cefazolin, all of the cephalosporins here. We've got ertapenem, gentamicin. All of these S's mean that this particular strain of E. coli is sensitive, except for ciprofloxacin. But there's more about ciprofloxacin I'll mention in a second. We also have nitrofurantoin, known as Bactrim. We have piperacillin and tazobactam, tetracycline, tobramycin, and trimethoprim sulfa. Now, anything that has an S next to it is something that the bacteria will respond to. This will lead to the clearance of this infection. But notice that some of these medications are not available orally. You don't administer ampicillin orally. So this is almost like they assumed that this was a non-pregnant person in the hospital. Why do I say non-pregnant? Because we don't give ciprofloxacin, we don't give levofloxacin to pregnant women. We don't give tetracycline to pregnant women. So you have to be very thoughtful about this. There are some medications here that we do often give to pregnant women, including cefazolin, also known as Keflex. We often give trimethoprim sulfa, Bactrim, to our pregnant clients. We give nitrofurantoin, also known as Macrobid, to our clients. So, you have to use this to guide your recommended antibiotic regimen. Back to our principles, you're going to treat from 5 to 7 days. You also have a different frequency during the day that these medications should be prescribed at. And some of these medications actually come in different doses as well. So all of that goes into the sort of general therapeutic strategy that we bring to our clients. And here are some of the more common regimens. The two favorite for me are Keflex and Macrobid. Okay, Macrobid comes in a low dose. It is not bactericidal. I mean, it doesn't kill the bacteria. It just helps to keep them from populating, right? We'll just leave it at that. So really fancy. It's fancy, but it's also very well tolerated by pregnant women. And you can do that for 5 to 7 days. I usually do this 100 milligrams twice a day for 5 days is what I like to do, because we want to use the lowest effective dose possible. It is not generally recommended in the first trimester, but if there's no other alternatives, I have no problem using it in the first trimester. The only exception to that would be, okay, or I guess an example of this would be, okay, Keflex isn't useful in the first trimester because of, the sensitivities report says that this E. coli is resistant, which is unlikely with E. coli. So we'll just use Macrobid instead, right? But if it's a pyelonephritis patient, I'm never using a Macrobid because a Macrobid does not really concentrate well in the kidneys, and we have a kidney infection there. So we have to consider all of this. Phosphomycin is not generally reported, but there's almost no resistance as far as I'm aware to phosphomycin, and it's a one-time 3 gram. That's a heavy dose once. Will treat any bladder, almost any bladder infection. However, it's not used in pyelonephritis for the same reasons that we don't use Macrobid. So this is another little table that's from this ACOG document from 2023, which I'll include as well here as a part of this presentation. So, you can use this and just take a look at it. You can see Keflex ranges from 250 to 500 milligrams orally every 6 hours, meaning 4 times a day for 5 to 7 days. And I would base the dose and the frequency, or let's say the duration of therapy, on how likely do I think that the lower dose or the 5 days would clear this infection versus 7 days. Are they diabetic? Are they smokers? All of those factors come into play because I know, generally speaking, how their immune system is probably working. And these antibiotics are supporting their immune system in clearing the infection and preventing it from ascending up to the kidneys. There's tons of non-pharmaceutical options. D-mannose, Eucora is a D-mannose product that has some other stuff in it. I think it has like vitamin C and zinc, those types of things. Uva ursi is an herbal tonic that can be very, very potent in the airways and the urinary tract. And then cranberry juice or cranberry extract are also great options. That's all for this. If you have questions, of course, you can reach me. It's nathan@belovedholistics.com. This is really just a reminder of some of these principles, and there's always going to be cases in which you really do need help. This is not my effort to punt future questions. I want you to ask questions. I also learn from those questions, but I want you to be thinking about all of these things. Anytime a woman comes to you with signs or symptoms of a bladder infection or maybe even pyelonephritis, or if they just have a routine screening or analysis with culture that shows bugs, I want you to be aware of all of this. I'll include a document that also clarifies when are we treating bugs, like at which CFU count are we really interested. GBS is a really important one where, okay, yes, we label them now as GBS positive. Do we necessarily treat GBS? I don't treat it unless it's 100K or more. You could argue treating it at lower CFUs, and this is like one of those things that's just been debated for a long time. So please reach out to me, and we'll make sure that we get your client the right care.